With this module, we will conclude our discussion of regulatory and ethical considerations in pharmacy. And I want to specifically think with you about ethical frameworks for pharmacists, maybe the most important discussion we'll have this week. As we begin this discussion, I'd like to kind of look back at some things we've already alluded to in our course. If you'll remember in week 2, I mentioned a document called the General Report of the Pharmaceutical Survey, which was published in 1950. This took a look at our profession and made a recommendation in the mid-20th century that we move to PharmD programs for the preparation of pharmacists. I want to read a quote from that document that refers to some other aspects of pharmacy and specifically some things we're going to talk about today. Hear this, written in 1950. The outstanding factor determining the future of the profession of pharmacy is fundamentally moral in nature. I find that very interesting. Think about the fact that here we were in 1950, post-World War II, lots happening in terms of the Industrial Revolution and manufacturing advances and all of that. And the report of the Pharmaceutical Survey says that the outstanding factor affecting the future of this profession is moral in nature, not political, not economic, not educational, not scientific or clinical. It's moral in nature. Isn't that interesting? I also want to think back to week 1 when we talked about the characteristics of a profession. You'll remember that we mentioned intra-professional control as one of those characteristics. We also mentioned that the establishment of codes of ethics are kind of descriptive of professions. Health professionals profess that they have the requisite knowledge to help us and they will act in our best interest. You'll remember that we talked about that as a social utility during week 1 when we defined professions. That social utility provides us certain social sanction, in this case a license, and that also provides a commensurate social responsibility, and we'll think about that in terms of ethical frameworks now. I would also like to think about this discussion of ethics and codes of ethics in a broader context. Think about the fact that our culture defines certain expectations and traditions that we would tend to follow in our societies, that our society establishes regulations and laws that we must follow, but it's the profession that provides a code of ethics, which is a powerful way of interprofessional control. As we think about ethical frameworks for pharmacists, I want to think about 2 specific contexts. And people do entire careers thinking about ethics and ethical frameworks, and we're going to talk about just a few little examples of things that we might consider in this situation. But I want to think about consequentialist and non-consequentialist frameworks. First of all, consequentialist. Things like utilitarianism, beneficence, and non-maleficence. So consequentialist frameworks means that it's the outcome of the act that determines its goodness or its badness. Utilitarianism, the most good for the most people. Beneficence or non-maleficence, meaning how can we maximize the benefit to people. So if I'm thinking consequentially, it is the outcome of the act which determines its ethical goodness. On the other side of that coin is non-consequentialist frameworks, which means that it's not the consequence that matters, it's the act itself. So we think about things like privacy and confidentiality. The fact that it's simply right to maintain patient privacy and confidentiality. Veracity or truthfulness, it's simply right to be truthful regardless of the outcome of that. Fidelity, the fact our duty to people and our loyalty. Justice, autonomy. And when we think about autonomy, I want to think about self-determination. And we've talked about kind of informed consent, the fact that we would have a competent patient, that they are well informed, they understand what we're telling them, and that they would voluntarily give us authority to move on with either a medical procedure or a research act. Think about informed consent when we think about autonomy. So I want to tell you that when we think about ethical frameworks and when we think about codes of ethics tend to be non-consequentialist in nature. Certainly the pharmacy code is. So it's not the outcome of the act that is important, it is the act itself. Now I want to provide for you a 4-step model for ethical decision making in pharmacy practice that was prepared by Robert Berkey and Lou Votero. And I will have on our website their book, which I'm holding in my hand, which is called Pharmacy Ethics, a Foundation for Professional Practice, that you can use as a book to learn more if you're interested. It's a well-written, provides case studies and more of a background about this problem of ethics in pharmacy practice. But I wanted to define for you their 4-step model for ethical decision making and review it briefly with you as such. So step one is to identify the problem, and we're going to look for things like what are the facts, what are the moral parameters and legal constraints around this problem, what are the human values involved. Step two would say that we would develop alternative courses of action around this problem, and we're going to identify the ethical principles of each course of action that we're thinking about. Step three is we're going to select one of these alternative courses of action, and then we're going to justify and defend that course. Step four is we will consider objections to the alternative that we've selected, and these could be factual errors, faulty reasoning, conflicting values, and so forth. Now, as we think about codes of ethics in particular, I want to kind of give you a little bit of history of the American Pharmacists Association's Code of Ethics for Pharmacists over time. So you'll remember that APHA was established in 1852. One of the first things that they did was establish a code of ethics. And I'm going to kind of give you some of these, how these codes changed over time, and it's going to be interesting for you to see how the focus changed. In 1852, the focus of that code was addressing fair business dealings. It was a lot of concern about adulterated drugs, and which is really part of why APHA came to be. And there was a lot of concern about counter-prescribing, which was pharmacists or apothecaries prescribing over the counter. In other words, they were prescribing. In 1922, this next version of the Code of Ethics actually prohibited discussing therapeutic effects and composition of prescriptions with patients. Isn't it interesting that early in our profession it was actually unethical for pharmacists to talk with patients about the therapeutic effects and compositions of the drugs they were dispensing to them? In 1952, we had another version of the Code of Ethics, and in this case, the referral of questions regarding therapeutic effects and composition of prescriptions was to be made to the physician. Again, pharmacists were really not to be talking to the patient about these prescriptions and about the therapeutic effects of them. In 1969, the version of the Code of Ethics was actually silent on patient counseling. So here we are in my lifetime, into the second part of the 20th century, and still the Code of Ethics does not address pharmacists actually working with patients to educate them about their therapies. In 1981, things started to change. We saw in the 1981 version of this code that the pharmacist was to render to each patient the full measure of professional ability. So it starts to think full measure, meaning I'm going to tell them what I know, right? And in 1994, the current Code of Ethics says that the pharmacist should assist individuals in making the best use of medications, and that a covenantal relationship exists between the pharmacist and the patient. You remember early in the course, one of our pharmacy fundamentals was covenant. So, the Code of Ethics now says that we have a covenantal, kind of a very almost moral, very deep obligation to the patient to act in their best interest. I want to take a few minutes now and review certain aspects of the current Code of Ethics with you. There are 8 tenets to it. I'm going to briefly describe each of those 8 to you, and so that you have an understanding of that code as well. So the current Code of Ethics first tenet says that a pharmacist respects the covenantal relationship between the patient and pharmacist, that they are going to help patients achieve optimum benefit from their medications. The second tenet states that a pharmacist promotes the good of every patient in a caring, compassionate, and confidential manner, and that the concern for the well-being of the patient is at the center of their practice. The third tenet states that a pharmacist respects the autonomy and dignity of each patient. This includes the right to self-determination, informed consent, and that the pharmacist respects personal and cultural differences between patients. The fourth tenet is that a pharmacist acts with honesty and integrity in professional relationships. They have a duty to tell the truth and to act with conviction of conscience. The fifth tenet is that a pharmacist maintains professional competence. The sixth, a pharmacist respects the values and abilities of colleagues and other health professionals. The seventh tenet is that a pharmacist serves individual, community, and societal needs, but the primary obligation for the pharmacist is to the individual patient. And finally, the eighth tenet is that a pharmacist seeks justice in the distribution of health resources. Having just reviewed the current Code of Ethics for Pharmacists and its 8 tenets, I'd like to take another minute with you and think about a contemporary example of an issue where these tenets can come to bear. I want to think about the pharmacist conscience clause, or the right for a pharmacist to voluntarily remove him or herself from a therapy to which they have a moral objection. And also the pharmacy fundamental of corresponding responsibility, meaning that the prescriber and the pharmacist have a corresponding or equal responsibility as to the legitimacy of a prescription and its dispensing. So the pharmacist has responsibility and some autonomy here in terms of whether to dispense or not. How does that apply to something like the duty to dispense? And I'll use the example of oral contraceptives. If a pharmacist has a moral objection to the use of contraceptives, should he or she be able to withdraw from that therapy in that process or that dispensing process with the patient? On the other hand, what does this mean for the patient in terms of their autonomy and their right to self-determination, and in terms of their some potential harm that could happen to them if these medications are not dispensed? If we think about a specific example of emergency contraceptives, drugs like Plan B, which don't require a prescription but will require a pharmacist's involvement. If the pharmacist has an objection to this therapy, should he or she be able to not engage in that therapy? And what does that mean for the patient in terms of their autonomy and their health and their well-being? As you can see, these issues are not clear-cut. They are not black and white. They can become very gray very quickly. Let's look at our pharmacy fundamentals for this module. Pharmacist conscience clause means the right to refuse to provide pharmaceutical services based on moral objections. And corresponding responsibility means a doctrine emphasizing that both the prescriber and the pharmacist are legally responsible for the proper prescribing and dispensing of medications. And then finally, here is our question that I'd like you to consider around this module in our discussion forums this week. And that is, what do you think are the biggest ethical challenges facing pharmacists today? Well, with this module, we've finished our discussion of regulatory and ethical considerations in pharmacy. Next week, we'll enter the last week of our course, and we'll think about some contemporary issues and the future.